and growth scans were all normal. Coming to past history, there is no history of diabetes or hypertension or hypothyroidism or bronchial asthma. There is no history suggestive of any autoimmune disorders or thrombotic episodes in the past. There is no history of any previous coughs or cough contact. Coming to family history, she was born out of non-consanguineous marriage, third in birth order. No history of similar complaints in any other family members, and there is no history of any familial renal disease. Coming to personal and nutritional history, she consumes mixed diet. Her calorie intake approximates to about 2000 kilocalorie per day, and her protein intake is about 60 gram per day. Her sleep and appetite were normal, bowel and bladder habits were normal, and she had no addiction.
So can you summarize, Suguna, what did you say? You have given
Yes,
a fairly good history, but can you summarize? I mean, what have you said history-wise?
yes, ma'am. So there is a 29-year-old female ma'am came to our maternity hospital with the history of bleeding TB. Her parity index was G2, P0, and E1 at that time. And she was, because of probably fetal distress, she was taken to emergency LSCS, and she had history of decreased urine output, new onset hypertension, and low platelet count, as she remembers, during post-op period, and she was referred to nephrology department for the same.
All right. So that's what you have said. You have summarized this history. What points did you look for in physical examination? Can you just elaborate on that?
Yes, ma'am. So, general physical examination, she was conscious, oriented to time, place, and person. She had pallor, but there was no interest or field edema or lymphadenopathy. Pulse rate, 96 per minute, regular. All peripheral pulses were felt equally, no radioradial or radiofemoral delay. Her blood pressure was 140 by 90 millimeters of mercury in right upper limb sitting position, and saturations were 99% on room air, febrile. Hair, teeth, eyes, and skin were normal, and she had a right IJV catheter. Her height was 157 centimeters, weight was 55 kgs. And coming to systemic examination, respiratory system, CVS and CNS were normal. Her abdomen, it was soft with no tenderness. LSC scar was present, trigravidarum.
Okay, so you have examined her after she was shifted to your unit, and that was one day after her delivery. Is that right?
Yes, ma'am.
Okay. So with any other specific findings you will look for when you are examining a case of pregnancy-related renal problem?
Since it is the postpartum period, I would give great detail to scar, ma'am, especially. So whether it is healing properly or not, whether there is any discharge from the scar side, and also I would look for breast tenderness, ma'am, if there is any. And since she had low platelet count as well in the history, I would also look for any purpura or petechiae that she might have on the skin.
All right, all right. So with this history and physical findings, what you've mentioned, what is your syndromic diagnosis when you see such a lady who comes to you with oliguria one day post cesarean with the history you have given?
Yes, ma'am. I would keep my syndromic diagnosis as pregnancy-related acute kidney injury.
All right. So you said pregnancy related, and she presented to you after delivery. So when do you use the term pregnancy related?
So AKI during pregnancy up to 6 weeks postpartum is termed as pregnancy-related AKI.
All right. So either pregnancy during pregnancy or till 6 weeks postpartum, you would call it pregnancy related. Or okay, you said AKI. You don't have a creatinine report for her. So why did you say AKI for her?
Because she did have history of oliguria lasting for more than 24 hours, ma'am. So according to Kari, that itself is enough for diagnosis of acute kidney injury. So I would say it is acute kidney injury. And
All
also
right.
she had predisposing factors like she had bleeding prior to the presentation, and she's also a post-op patient. So I would consider these as predisposing factors. So I would say it is acute kidney injury.
Okay, so you say that it's pregnancy-related acute kidney injury.
Yes.
Right. All right. So what are the common causes of brachy that you know of, and what do you think would be the cause, or what could be the causes in this lady?
So most common causes of brachy, I would say, is preeclampsia, ma'am, followed by sepsis and hemorrhage. Uh, in this lady also, I would keep my first differential as preeclampsia only, postpartum preeclampsia. And then second differential, I would keep as acute tubular necrosis. Third differential, I would keep as first differential preeclampsia. Second differential, I'll keep as health syndrome. Then thirdly, I would say TMA, considering new onset hypertension and platelet count. And then uh, later, little lower down in the differentials, I would keep ATN and acute cortical necrosis as well.
So, see, in fact, I would consider ATN as the first cause because she has a significant history of bleeding PV and she presented to you immediately after that with oliguria. So, why can't the ATN be a first differential? Fine. So, you have listed some differentials. You have told that whether it could be preeclampsia or it could be a HELP syndrome, or you said it can be an obstetric hemorrhage, or it could be, you said, thrombotic microangiopathy, right?
Yes.
So, I mean, okay, these three look fair enough. So, in India, what are the common causes you encounter mostly? What's the first common
Yeah.
cause in India?
First common cause is preeclampsia, hypertensive disorders of
So,
pregnancy only.
sorry to intervene, Dr. Suguna. Have
Yes,
you,
yes.
how much was the bleeding with which he presented? Was it sufficient enough to cause hemodynamic disturbances? Or
Actually, there was no
that
history
history
of.
probably was not
It
forthcoming? I
was
thought
there,
so.
sir. She has mentioned that
Actually,
there
she
was
has
no
mentioned that,
hypotension.
she did mention that her clothes were drenched in blood, but there was no history of any hypertension as such.
So, she's mentioned that there was no hypotension and there was no history of any blood transfusion. So,
There
probably,
was, Suguna, there was no history of hypertension during pregnancy,
no,
isn't it?
No,
no,
sir.
no.
No hypertension.
So,
So,
yeah.
no.
Yes. So, Suguna,
So,
you said that there was no hypertension during pregnancy, but still you have
No.
entertained preeclampsia.
yeah.
Yes, ma'am.
So, when does preeclampsia generally occur?
After 20 weeks of gestation, ma'am.
Okay. So, can it occur after postpartum period, also after
Yes,
delivery
ma'am.
with a normal
Yes,
pregnancy?
ma'am. Even if antenatal period was normal, postpartum preeclampsia can also occur. I mean, preeclampsia can occur postpartum in about 20% of cases, ma'am.
All right. So,
But
how to
did,
define
did, did
preeclampsia then?
Suguna, this lady,
Yes, sir.
she had no hypertension during pregnancy.
No, sir.
Even after coming here, after her blood pressure is 140 by 90 millimeter.
That is on
I am with that.
antihypertensive, sir.
Then
She was
why did
already
you
started.
She
say
is on two antihypertensives, sir.
She
That's
was
what you
already.
said. So, blood pressure is, you said 140/90, and is that without antihypertensives or
No,
with?
ma'am. The antihypertensives were started in the maternity hospital itself and we continued them. On the
Okay.
antihypertensives, it was 140.
Yeah, so that's what you mentioned, that she was on two antihypertensives. The pregnancy was normal according to her, but
Yes.
on the day she was admitted to maternity hospital, she was found to have hypertension. So see, here the confusion is you have given three differentials, ATN, or you said that it's preeclampsia, HELP, or you said that it is probably TMA. Now, can you tell me points in favor and against of each of these? For example, preeclampsia, you said that it can occur postpartum, 20% cases. I agree. Hypertension is there. Then what is the other defining feature of preeclampsia?
Proteinuria that we do not know until now, ma'am, but she does have AKI. So one of the features of preeclampsia could be maternal organ dysfunction as well, even in the absence of proteinuria. So yeah, I would entertain that possibility as of now.
Okay. And what about the possibility of TMA you entertained? Why did you put that possibility? What are the features of HUS or TMA?
So first of all, it is the timing, ma'am, because HUS is most common in postpartum period only. So first is the timing, and then there is this new onset hypertension and also thrombocytopenia. With a combination of all these three, I would like to entertain a possibility of TMA.
But would you expect HUS to occur on the first day itself? How soon after pregnancy can HUS
Yes,
occur?
ma'am. It can occur within 48 hours of delivery only.
Okay, so how do you generally differentiate preeclampsia and HUS? What would be the course you would expect? You are seeing her now on the second day itself. So, okay, the diagnosis is open. It might be preeclampsia, it might be the beginning of an HUS, but what would happen during the course? And what would differentiate between these two in clinical practice?
So if it is preeclampsia, ma'am, it would probably resolve within 7 days. I mean, it will at least begin resolving by some third to fifth day postpartum, and it will resolve within the first week of postpartum. Whereas TMA doesn't resolve. It will keep worsening without treatment.
Yeah,
So
so
that
that's
is
an
one.
important point that preeclampsia generally resolves. You said preeclampsia and you also said HELP. So
Yes,
do you
ma'am.
think this is mostly HELP syndrome you're talking about, or you're thinking it's preeclampsia? How common is AKI with preeclampsia alone? Can it occur with
Actually,
preeclampsia alone?
it can, but very less compared to HELP syndrome. So for this patient as such, I would go more in favor of HELP syndrome than preeclampsia, ma'am, actually, considering the low platelet as well, and even the AKI also. So I think HELP syndrome is most likely compared to preeclampsia.
Fine. So you have given some three differential diagnoses. You also, I mean, there are other differentials also where you can have, as you said, thrombocytopenia, and you can have brachy. So can you name some of the other varieties which you have not listed here and why you have not listed them?
Okay, ma'am. So, other conditions with thrombocytopenia, there could be Apla syndrome as well, ma'am. That also can present with thrombocytopenia. So, that I have not listed here because the patient did not have any clinical history which is pointing towards that Apla syndrome. She doesn't have any thrombotic episodes in the past. She did not have any pregnancy losses in the past. That's why I did not consider that possibility, ma'am.
What about TTP then? You did mention that. So TTP,
Yes,
why
ma'am.
can't it be TTP?
Because first of all, the timing, ma'am, TTP commonly occurs during the second and third trimesters of the pregnancy. Now, on top of that, AKI is not predominant in TTP, ma'am. It is predominant in AKI, whereas neurological features are more predominant in TTP. That's why I would keep that in lower down in the differential, ma'am.
All right. So you have
One
basically,
small thing, Suguna, I have a
Yes,
basic
sir.
doubt. On
Yes, sir.
what basis are we discussing this case as a case of preeclampsia?
Because the
Do you have any other findings? You have not done the urine examination.
so
You have not done any history.
as of now, only clinical, sir. Clinical,
And
this is what
clinically,
is given.
except for hypertension, she has no other clinical history to suggest that she had preeclampsia.
except for new onset hypertension, sir, actually, and the AKI. So I would go more towards health. But other thing is, it is the most common cause of trachea, which is why I'm entertaining it as the first DD.
Fine. So let us all resolve this confusion. So you have given a differential of either ATN or you said TMA, and you did mention preeclampsia, to which I would agree that postpartum preeclampsia can occur with new onset hypertension of day one. And it can cause organ dysfunction, though less common. But again, it's the commonest cause of brachy. But again, we can't say with this history. So to solve this confusion, what investigations would you want for her?
So I would send a panel of hemograms with peripheral smear, ma'am, and I would send renal function, liver function tests, and serum electrolytes, and then I would send complete urine analysis and proteinuria estimation. And I would also send LDH levels, haptoglobin, Coombs test, and I would also send coagulation profile, PT, APTTA, INR, and D-dimer and 5-decogen. I would also check for blood cultures, urine cultures, and also CRP levels. And I would also go for renal ultrasound as well.
Okay, so you have asked for some of the basic tests. So let us find out. I mean, so you have given a list. Now you tell me, what do you expect in this? You have given me three or four diagnoses. Now, how will urine examination help you? You asked about the urine examination. So how will it help you differentiate between ATN or TMA or preeclampsia health?
Coming to the DDs that I've given, ma'am, in CUE, say the case is acute tubular necrosis, we might see some multi-brown casts in the CUE. And again, coming to preeclampsia, there might be 1 plus proteinuria, minimum proteinuria, or 24-hour, there can be 1 plus proteinuria, ma'am. And coming to TMA, there could be hematuria present, but again, that plus or minus. In case of severe thrombocytopenia, we can have that. Otherwise, it can be normal as well.
Okay, fine. So in Indian setting, even puerperal sepsis is common and may complicate
Yes,
the
ma'am.
other conditions. So would CUE help there?
Yes, ma'am. Presence of pus cells in the urine, nitrate being positive, leukocyte esterase being positive. So that would help in pointing the source of sepsis.
All right. And suppose it's drug
If
induced, some result, can you CUE help with that as well?
Yes, ma'am. Eosinophil cast would mostly point towards AIN. So That
Okay.
would help.
Okay. So urine examination is a very valuable tool, often missed, and I think postgraduates should do it themselves. In case you have an active sediment with lot of casts in urine, RBC casts and all, what would you suspect then?
An underlying glomerulonephritis is mostly a possibility.
All right. So this lady didn't have all those features, and as of now, you have told that what would you expect in the urine examination. And now this is the report. She had 1+ protein, 2 RBC per hyperfield and 3 WBC per hyperfield and no casts. You have asked for the other reports as well. So what do you expect on CBP then?
So CBP, I would look for HP whether it is low, and I would look for leukocyte count. If there is leukocytosis along with toxic granules on peripheral smear, it goes more towards the septic cause. And then I would look for thrombocytopenia, ma'am. So if there is low platelet count, that would again favor the diagnosis of HELLP syndrome and TMA as well. And then in peripheral smear, I would also look for any evidence of MAHA, like histocytes are there or not.
Manisha,
So-
to cut down the time, can we go ahead with the investigations and then you can question her on that? I think that will be
fine.
better.
All right. So these are the investigations. You can see the hemoglobin was low, leukocyte count was normal, platelets were low, cystocytes were present. You can see the fragmented cells there in the picture. And then again, these are the investigations. Creatinine 4.5, bilirubin was normal, liver functions were normal, enzymes were normal, electrolytes normal, INR normal, LDH is 4135, significantly elevated. The CRP was negative. The urine culture came back at 72 hours negative, and the viral markers were negative. Coombs test was negative as well.
So now, Suguna, you tell us, what do you interpret so far?
So since the LFTs are normal, I would take HELLP syndrome out of the picture, sir. And since there is thrombocytopenia and schistocytes were present and LDH is also elevated, so that is the evidence of MAHA. So thrombocytopenia with MAHA with AKI. So I would keep TMA as my first differential now.
So can you have that picture in any other DDs you mentioned? Can preeclampsia have this even without HELP? Because HELP is not there. The liver enzymes are normal, but preeclampsia, can it have MAHA?
It can have MAHA, ma'am, but AKI being this prominent is not usually expected in preeclampsia.
What about TTP? Can it have a MAHA picture?
TTP can have a MAHA picture, but then it wouldn't have AKI as the prominent feature. And also the thrombocytopenia would be more severe. It would be less than 30,000, but here it is somewhere around 40,000. So I would also take it
So
out.
diagnostic of TTP is what test?
ADAMTS 13 activity.
So if you are not able to send it, it's costly and it's not available. So any other alternative method you can use for diagnosing or excluding TTP?
There are a couple of clinical scores, ma'am, plasmic scores and FEN scores. So that those are used to stratify the risk of TTP. We can use those in the clinical context.
All right. So what is the basis of those scores? Basically, what do they look at?
They look at the creatinine and the evidence of active cancer. I mean, the secondary causes they'll rule out. They'll see the platelet count. They'll see the INR profile.
So it's important for postgraduates to remember, even without the ADAMTS, it's very important. TTP does not present with AKI generally, and platelet count is less than 30 generally, and creatinine is not more than 2. Ultrasound was done. It was normal. What else? Now you have a MAHA picture. So any other secondary conditions can cause MAHA. You have listed some of the conditions. Any other tests you want?
I would like to send autoimmune profile as well, ANA profile, ANA extended profile, and APLA as well, because that also might present with MAHA. So I would send that. So, and C3, C4 also together.
All right. So all these were negative. What else will you do?
So now that if the patient is falling into low risk category, I would probably keep atypical HOS high as the diagnosis now. And since the patient already has oliguria for more than 12 hours and her creatinine is also 4.5, first and foremost, I'll start her on renal replacement therapy, ma'am, and start her on hemodialysis.
Would you like to send any other investigations?
Underlying complement genetic mutations, I would send genetic testing.
So any case of TMA, before you start on any sort of therapy, you would like to send the complement. You will at least like to keep the sample for complement and genetic mutations. That's right. Okay. All right. So what treatment would you give for her?
So in case of TMA, I would start her on flex immediately, ma'am.
Okay. And what about renal replacement therapy?
Renal replacement therapy, I would start her on right away, ma'am. Before starting flex, I would take sample and save it for ADAM-TS13 and complement factors and genetic testing.
What sort of dialysis will you advise for her?
Since she's a postpartum patient, I would give the standard prescription only, ma'am, the standard 4-hour dialysis with UF according to her clinical scenario. And heparin, I would give cautiously because she has thrombocytopenia as well. So considering the bleeding and all, I would probably go for heparin-free dialysis.
Fine. What about Plex? Plex prescription, you said you'll start her on Plex. What are the indications of starting on Plex?
For TTP, we start on flex, ma'am.
But
And
we're not sure about that. And you said we have almost ruled that out.
yes, ma'am. In case of atypical HOS, actually, we started a complement inhibition. Eculizumab is not available. We can start her on flex. And also in case of anti-factor H antibody positivity, also we'll start her on flex. And even like unclear diagnosis in case of TMA, also we can start her on flex.
Okay. So you have started her on dialysis. You have started her on Plex. So how long will you continue the Plex therapy once you have started her on that?
Usually, daily flex has to be given, ma'am, until the hematological parameters improve, until the LDH normalizes and platelets improve to more than 1.5 lakh. I would give her flex daily.
All right. So you are treating her for MAHA and AKI. You have started her on Plex. You have started her on dialysis. She continues to be oliguric. The parameters still continue to be abnormal. And now she has reached the second week. She is on regular dialysis. Plex is continuing. The platelets have improved, but they have not normalized. They are now around 1 lakh. What would you do? I mean, you have sent off the investigations as well.
So since it has been 2 weeks and she hasn't recovered yet, I would want to go for a renal biopsy, ma'am.
So do you think that the renal biopsy will help you in diagnosis of TMA?
No, ma'am. TMA is a clinical diagnosis, but at 2 weeks since after giving flex sessions also she did not improve. I would like to see if there is any other etiology like maybe acute cortical necrosis also. So I would like to do biopsy in order to rule out other etiologies as well.
So you are thinking that primarily she has TMA, but the oliguria is not improved and you would like to rule out other etiologies. So what do you generally get in biopsy?
In TMA, ma'am?
In a Prachi case?
In a Prachi case, in case of preeclampsia, we'll get endotheliosis. And in case of TMA, we will get endotheliosis, mesangiolisis, and platelet-rich fibrin thrombi in vessels. And in case of ATM, we'll have tubular injury with loss of brush border.
So does literature suggest that you can have this cortical necrosis with TMA, what you are mentioning?
Yes, ma'am. There are certain case reports where they have specifically mentioned that acute cortical necrosis on biopsy, we should rule out TMA as well.
All right. So biopsy was sent and the biopsy showed these features, mesangiolisis and ischemic changes in glomeruli, focal endotheliosis, wrinkling of basement membrane, and mild endocapillary prominence, and one glomerular cellular crescent, but otherwise fragmented RBC in capillary lumina. The tubules show loss of brush border, some hyaline casts in occasional tubules, rare tubular atrophy, interstitium widened edematous, and vessels, again, myointimal hyperplasia, fibrin thrombi with fragmented RBC, no significant immune deposits, and it was reported as glomerular and vessel changes of TMA. And further evaluation was recommended for etiology of TMA. In the meantime, these are the complement levels which were obtained. C3, C4, factor H, factor I level were normal. Anti-factor H antibody was negative. So where are we now? What do you say?
I would wait for the genetic reports, ma'am.
Can you have a normal complement, completely normal complement in case of HUS?
Yes, ma'am. 20 to 30% of cases might have normal complement levels. It is not necessary that every case should have low C3.
All right. So, fine. So you are still entertaining the diagnosis. All right. So now the course was by third week, she started improving, platelets normalized. Hemoglobin normalized.
Shall I ask her
Creatinine.
one thing?
Yes, sir.
In a postpartum period like this,
Yes, sir.
what is the differential diagnosis for thrombocytopenia in this setting? And then what is the other things we are consider if the patient has renal failure? And low complement, more important, those who have low complement.
Lupus nephritis also I would consider as a
Yes.
possibility,
So
sir.
how do they present?
They can actually present during any time in the pregnancy or postpartum period as well. They
But
can
what
present
is the
symptoms.
usually vulnerable period or the usual presentation of lupus nephritis during pregnancy? What is the
So
class?
the patient presents with acute nephritic illness like picture only with new onset hypertension and
No, which phase of pregnancy? Just I wanted to ask you, which phase of pregnancy the
uh, it can occur during any time, so during pregnancy, and it actually predominantly I think occurs commonly during the second and third trimesters.
So what sir wishes to ask is generally flares occur post-abortum or
post? Yeah.
postpartum, generally around that period of
Mm.
time. But anyhow, because you had said asked for autoimmune profile that was negative, and so that's why probably in this case it's not a differential, but that's the point sir was wanting to make, post-abortum or postpartum, and that's why many of the times we increase the steroids when during these phases. So probably that's what sir wanted. So luckily the patient improved, and dialysis and plex was stopped, and then creatinine even came down to 1.5 one month postpartum. So are you happy about it? You have a complement workup normal, she's improving. So what do you think? Should you discharge her and forget about it, or would you
No,
still
ma'am.
want that report that we have sent a
I
genetic
would
report?
still want the genetic report, ma'am, because in pregnancy associated TMA cases, about 60 to 70% cases will have underlying complement dysregulation. So
Fine.
I
This
would,
is the genetic report we got, the clinical exome by NGS, no pathogenic, likely pathogenic variants causative of the reported phenotype. What do you say?
this still doesn't rule out, ma'am. MLPA report also should be there because this NGS can't pick up the copy number variants, genomic duplications or deletions. So I would,
Fine, that's right. So this was the MLPA report. Susceptibility allele associated with phenotype has been identified, heterozygous deletion, and CFHR4 and CFHR1. They are duplicated, and MLPA probe ratio 0.48 to 0.63 showing heterozygosity, hemolytic uremic syndrome, atypical. And that this is the report which is given. So how do you interpret this report?
so this could be considered as the first hit for her, ma'am. This is like an actress. It means that the patient was susceptible for TMA, and the pregnancy must have acted as a trigger, second hit, manifesting the issues during the postpartum period.
All right. So what do you think about eculizumab now? We couldn't give
It
it
can
early. So what do you think is the correct time for giving eculizumab? Would you give her
actually,
now? And if it was available to you, would you have considered it early in pregnancy?
I would have considered it instead of flex. I would have given Kulizumab if I had the resources now.
But suppose now, what do you think? Will you give it now for her? She is improving.
No, ma'am. Now that the parameters are settled and the trigger is removed, mostly we would try to follow conservative management only.
All right. But what's the Western guideline now? I mean, most of the guidelines do recommend if you have a strong clinical suspicion and plex does not improve the patient within a week, probably
We
eculizumab,
should go ahead.
it completely changes the outcome. All right.
Yes.
So this patient now, you have discharged her. You have not considered plex for her, eculizumab for her. She is doing well. What sort of complications she can have in future? What would you like to monitor?
I would like to monitor her hemogram, her renal function test, her urine analysis, and her C3, C4 levels as well, ma'am.
So can these
How about
patients
how
progress to
about how
CKD?
about Suguna? How about
Yes, sir.
urinary protein? Now that she
Urinary
has a
protein.
good urine output has improved and all, would that suggest the degree of residual damage that would have been, even though the creatinine is 1.5? Do you expect that there would be a significant chronic damage in her
Yes, sir. But I
organ?
would wait until 12 weeks postpartum to see how these investigations are faring. After 12 weeks, then I would send all the investigations again and then assess the damage.
Yeah,
Whether,
I think it's very important. And I think eculizumab, if I had eculizumab, I would rather give it in the first suspicion that this was thrombocytopenia. Time is very essence.
Absolutely.
giving eculizumab to prevent chronic damage, irreversible damage to the kidneys.
Absolutely.
And unfortunately, many times it's not available with us and procuring it. Even if patient is willing to buy it, acquiring eculizumab in timely fashion is difficult. Many times you have to import it and therefore may not be available always in the market. So therefore, otherwise the treatment of choice in a patient like this would be as soon as you make a clinical suspicion of an atypical HUS or even hemolytic uremic syndrome of any cause, in this kind of a setting with the background of complement mediated disease prevalence, I think I would definitely feel that if somebody can afford eculizumab, then that would be this thing that one should be trying to use.
So
And
absolutely.
time would be very essential.
Yeah. So eculizumab changes the outcome. I mean, otherwise
Yes.
patients 70% go into ESKD, 70 to 90%
Yes.
without eculizumab. So the message is that once you diagnose MAHA and it's persisting beyond 72 hours, it is mostly HUS complement mediated in this pregnancy setting, and eculizumab should be given early, hit hard. So that should be the dictum. So we should not wait for the genetic reports to come or for the complement levels to come before we decide. So, so one question here,
Manisha,
yeah. So just one,
thanks everyone for including me as a panelist. Just
Yeah. Please.
Pleasure, Dr.
Silvi, please
go ahead.
Suguna,
Yes, ma'am.
if eculizumab was available, as everybody has pointed out, we should start it. We should give it early. But what about? What is the? How often or how long would you give eculizumab?
Actually, in this, typically we will give for 6 months, ma'am. But if there is an underlying rare complement genetic mutation, we might have to give it lifelong as well.
how will you give? Madam is asking how much dose will you
900,
give?
okay. 900 mg weekly for first 4 weeks, ma'am. Followed by 1200 mg on week 5, followed by 1200 mg once every 2 weeks.
Okay, but is it dialysable? It has to be started early. She's also on dialysis. So would you modify the dose with creatinine clearance?
ma'am.
Is it
Not-
dialysable?
No, ma'am, it's not. We don't need
So
it.
that's
Because it is a
important.
monoclonal antibody, so it's not dialysis.
What about plasmapheresis? Does it remove eculizumab?
Plasmapheresis,
So
it
that's an
might.
important point. It removes eculizumab. So you
Yes,
should
ma'am, it
not
might.
give it and do a for plasmapheresis. So
You
Yeah,
should
actually,
not
when
give
you-
eculizumab after plasmapheresis.
Yes.
Yes.
yeah.
Yes.
So suppose now this lady wants, okay, fine, you will follow her up and
So,
Dr.
Manisha, 1 minute.
said-
Dr. Mohan Rajapurkar is waiting for some time. He wants to ask something. Dr. Mohan, please go ahead.
Sorry, sir. Sorry, can't see sir on the screen. Yes, sir,
Yeah.
please.
No, that's okay. I had no hurry. I just had 2 practical points. So when you said investigation, you wanted urinary protein creatinine ratio. I think this test, in the presence of oliguric acute renal failure,
That's
is worthless.
But
Number one. So you should have asked, if you wanted to quantitate it, then you had to do a timed collection. That is number one. Secondly, I could not understand what was your indication for dialysis. There was not much fluid overload. The blood pressure was not difficult to control. And
Actually,
and
there
you
was a-
you also mentioned that you will do a standard hemodialysis, which means what? 4 hours QB 300, QD 500.
for the first dialysis,
Is
I'll
there no
be doing-
difference between acute kidney injury and chronic prescription, because the chronic prescription is done by the technicians and not given by us?
Yes, sir. For the first session, I would most probably go for 2 hours only with lower blood rates and lower dialysis flow rates.
No,
sir.
but when you were
And-
asked that question, you said it's standard hemodialysis. That's why
Okay.
the answer should not be that.
Yes, sir. And actually, she did have oliguria for more than 24 hours, so that's why we dialyzed that patient.
I understand. I'm not
Yes.
disputing the basic indication. Then you needed to have it done much more carefully under your observation and not just say standard, which a technician could do.
Yeah,
Yes.
absolutely. Maybe because of constraints of time, sir, we did not elaborate. I should have asked her also specifically. So, yes. So, Dr. Rajapurkar makes a very valid point. So,
Manisha, you're not appearing for the exam.
no, I'm just thanking you for pointing out that point, which was important. Yeah, Dr. Silvi, you want to say something?
So, yeah, I have a question. So, if you had eculizumab available, you would have, I'm assuming you would have given that first after you get the results of Adamas 13 and
Yes, ma'am.
TTP is ruled out. Would you still
Yes.
be doing Plex in this
No,
patient?
ma'am. If we've given eculizumab, then we would not do Plex.
So, is there an indication of doing Plex when we have atypical HUS and we are not suspecting TTP?
Yes, ma'am. If eculizumab is not available, that is one point. And again, if there is anti-factor H antibody positivity, also we can do it, ma'am. And in unknown etiologies where even there is absence of any complement gene mutations or at-risk haplotypes, and no other etiology is being found out, then also we can go with Plex.
Okay.
Suppose she wants to become pregnant again. What would you say, Suguna?
I would ask her to consider, because the risk of recurrence is high in case of atypical HUS, and on top of that, she also has a complement dysregulation number, like genetic mutation as well. So I would say that in subsequent pregnancy, she might have actually an earlier onset as well, and it might be more severe and less responsive to treatment, and she might land up in ESRD as well. So I would ask her to consider all that before planning the next pregnancy.
All right. So
One small doubt, Suguna. We are
Yes,
all
sir.
talking about availability, administration of eculizumab and other form of therapy.
Yes, sir.
We are in a resource limited setting. We know that. We
Yes,
are part of
yes,
that.
yes. Yes,
So a patient, when we don't have all these facilities, we don't have it. Simple dialysis and any other modality or any other help in the dialysis while doing dialysis, anything else is helpful in such cases? There was a time when nothing was available, even plasma exchanges were not easily available. Even now, the current recommendations in resource limited settings, there are recommendations that these patients can still be managed when you don't have anything else. At least a FFPs can be given in these patients to,
okay. Plasma transfusion.
yeah.
Yes.
So please go ahead. Yeah.
suppose she lands up with CKD, end stage kidney disease, unfortunately, despite all your efforts and guidance. So would you consider doing a transplant for such patients where you have this sort of a genetic mutation?
I wouldn't say I wouldn't go for transplant, ma'am. But again, risk of recurrence is quite high in atypical HUS, as high as 80 to 90%, with up to within the first year of transplant itself. So, if I have to go for a transplant, I would first counsel them regarding this, and rather than a living donor, I would go for a deceased donor transplant.
So what will you do? I mean, what about eculizumab? If you have eculizumab in your hand, does that alter the transplant prospects?
Actually, yes, ma'am. Prior to transplant and post transplant, also we can give eculizumab, and maybe it might like increase the longevity of the graft.
So can you, I mean, initially you said you will give prophylactically before the transplant and all that. So can you go ahead with the transplant, and then if she has a recurrence, can you plan eculizumab at that point of time?
We can do that also, ma'am. Preemptive or I mean, we can give prophylactic or therapeutic.
Yeah, so studies have shown that you need not start it prophylactically, but again, that's probably she already has a child, and maybe in India in resource limited setting, I don't think I'm advising pregnancy unless she has access to eculizumab. So that would be so.
Yeah, in fact, Manisha, I had a patient who had again prachi and cortical necrosis, and ultimately was planning for a transplant. And so we, with a previous experience of another atypical HUS patient who had again received eculizumab prior to transplantation and did successfully well, which we had done about 5 years back. And this time, now about a year back, this young lady was wanting to have a transplant. And so we went ahead and used eculizumab initially. So I used eculizumab a day before transplantation, and then every week for 4 weeks. We kept a fifth dose in case there is an emergency. So we gave only 4 doses for one month, 1 month post transplant, there wasn't anything else. So we kept one dose with us, which I kept for about a year. She's now about 1.5 year post transplant and has been doing very well. She had acute cortical necrosis related to a complement mediated atypical HUS during pregnancy and delivery.
Oh,
No, Manisha, can I ask one question?
yes,
Is there
please.
time?
Yes, please. Yes, please, sir. Good evening.
Yeah, we have not touched upon the liver transplantation in this scenario. I just want to clarify about liver transplantation. In a case of atypical HUS, we have actually I had one patient who underwent liver transplantation, and then she improved. We had covered her with eculizumab for that time period, and then after that, of course, we lost her because of complications of liver transplantation rather than. So there is a role for liver. We actually sent her for a partial liver transplant, but then they ended up doing a total liver hepatectomy followed by a transplant, which did not keep her for a very long time. But it's you have to consider that liver transplant also for replacing the missing factor.
Yes, sir. So your point is very valid, sir. We don't have
Yeah,
any
but-
types of liver transplant, but as we understand, if those with MCP mutations, we take only for kidney transplant, whereas factor H mutations, factor I mutations, liver transplant also, a combined liver kidney is what is recommended, but we don't have any personal experience in this regard, sir. But thank you for that input. So is there any alternative to eculizumab? Suguna, just asking. I know we are far away from getting eculizumab itself. So any other better drug available?
Actually, ravulizumab is tested and it is approved also, ma'am. So
How
it
is
has
it better than eculizumab?
it has more affinity to the C5 receptor and also the half-life is more, ma'am, about some 50 days compared to the 11 days of eculizumab. So it is more effective than eculizumab.
Yeah, so
I think maybe
that's the
Manisha,
end
we
of
should
the.
now.
Yeah,
Yeah,
I
that's the
think,
end of the
we should
I
have-
presentation.
think we have had wonderful discussion. I must compliment Dr. Manisha and also Suguna. Very well discussed case, and I think she is very well read girl. I think she has done very well. We have crossed the time. I think we will now request Dr. Silvi to go ahead with her presentation, and then we will have some question answers.
So thank you, Dr. Kher, for the invitation, and thank you to all the panelists. It's an honor to be here. And great presentation, Suguna. I think it was very well done. So congratulations on that. So I
Thank
would be
you, ma'am.
talking about pregnancy and acute kidney injury. So these are the learning objectives. We will talk about incidence and etiology of AKI in pregnancy, pregnancy risk assessment and counseling, diagnosis of pregnancy-related AKI, and management of pregnancy-related AKI. So why it is important for us to talk about pregnancy-related AKI is because the incidence has gone over, increased by 3-folds in the last decade. And there is, as we can see, the incidence is much higher in diabetic patients, about 0.8%. The incidence is higher with increasing maternal age as well. This was one of the studies which was done by our group. And what we can see is the incidence was highest amongst women who were between 41 to 49 years of age, with racial differences as well, with higher incidence in Black patients. This figure shows the classification of pregnancy-related AKI, which we briefly talked about. So in the first trimester, hyperemesis gravidarum and septic abortion are the most common causes, though the incidence of septic abortion is now growing lower with better facilities available. In the second and third trimester, a lot of causes and overlap, including preeclampsia, which we talked about, is the most common cause. We can have obstruction as well, which has to be ruled out. Glomerulonephritis, UTI, again, are common causes. And as we discussed, TTP and atypical HUS, again, are commonly seen in second and third. And in the third trimester and postpartum period, especially the incidence of atypical HUS may be higher, which our patient had. So again, kind of reflecting what we discussed in our case as well. And as we can see in the postpartum, there are only few which are most commonly seen. So we should keep these in mind when we are evaluating for pregnancy-related AKI. Now, why it is important for us to talk about pregnancy-related AKI and why we need a early diagnosis. So there is higher incidence of maternal mortality. There's higher incidence of cardiovascular events, preeclampsia, cesarean deliveries, which the patient had in the case discussed. Higher incidence of preterm births, low birth weights, neonatal admissions, stillbirth. So it's surprising, and actually it's good. Like the baby who was born was normal birth weight. However, with pregnancy-related AKI, you can really see adverse fetal outcomes. And this again, I wanted to show the results from one of our studies where we looked at the pregnancy-related AKI and clinical outcomes. And what we showed was the pregnancy-related AKI is associated with a very high incidence of inpatient mortality. So around 13-fold higher incidence of inpatient mortality or maternal mortality. There is 9-fold higher incidence of cardiovascular events. And there is also the 9% of pregnancy-related AKI needed dialysis, which our patient in the case needed as well. And why I'm talking about dialysis here is because there is higher mortality in pregnancy-related AKI hospitalizations that need dialysis versus that do not need dialysis. So it does lead to adverse outcome as well, needing dialysis with pregnancy-related AKI. So how do we define pregnancy? How do we define AKI and pregnancy? And that was my other question, which I wanted to ask, did we have any creatinine values before or during the course of pregnancy? Because the patient actually presented just with bleeding, and that's how she was found to have hypertension and AKI. And the reason is, at least here, and what I know in most of the countries, creatinine is not normally measured during the course of pregnancy. So there is a lot of times the AKI diagnosis can be missed unless that patient is admitted in the hospital. And the other thing is also, how do we define AKI? So the KDIGO guidelines really don't talk about defining AKI in pregnancy. And what a normal seeming creatinine, suppose if you have a creatinine of 1, it may seem normal, but it may actually indicate AKI if your baseline creatinine was lower. And this is something, data from one of the studies in Ontario, Canada, where they looked at the trend of creatinine during pregnancy. And as we can see, the pre-pregnancy creatinine, if it ranges between 0.7 to 0.9, it actually drops in the first trimester, second trimester, and third trimester, reaching to its pre-pregnancy value postpartum. So the point I'm trying to highlight here is, if you have a creatinine of 0.9 in pre-pregnancy and then you have a creatinine of 1.1 in first trimester, it's possible that may indicate AKI. But if you don't have a pre-pregnancy creatinine, you may think that creatinine is normal and a diagnosis of AKI can be missed. And I think it is often missed in clinical settings. So the next, we did talk about preeclampsia and hypertensive disorders in pregnancy being the most common cause of AKI in pregnancy. And this is just a classification showing how we define hypertensive disorders of pregnancy. So the most important, which Suguna did mention, is how preeclampsia is diagnosed as greater than 20 weeks of gestation. And if there is target organ involvement, it is a diagnosis of preeclampsia, even in the absence of proteinuria. And target organ involvement can be AKI, which is involvement of kidneys or elevation of liver enzymes, or cerebral involvement or hemorrhagic involvement, which could be thrombocytopenia or evidence of hemolysis. And this is the brief figure showing the pathophysiology of preeclampsia. So it is a placental disorder. And as we can see, there is incomplete invasion of the cytotrophoblastic cells into the spiral arteries. And therefore, there's improper remodeling of spiral arteries, which occurs, which results in impaired placental perfusion. And the other thing to remember is there is imbalance of anti-angiogenic and pro-angiogenic factors in preeclampsia. So there is increase in the levels of sFlt1 and endoglins, and decrease in the levels of placental growth factor and VEGF, which is responsible for vasoconstriction. This results in endothelial dysfunction, and glomerular endotheliosis, which we briefly discussed, is most commonly seen in the kidney biopsy. And this results in the multi-organ disease, which can be cardiorespiratory, renal, where we see glomerular endotheliosis, AKI proteinuria. It can manifest with eclampsia, stroke, liver failure, and with regards to hematological manifestations, it could be low platelets, DIC, and hemolysis. So why it is important for us to talk about preeclampsia or monitor patients with preeclampsia is also because it does have a lot of it can lead to have adverse cardiovascular and adverse kidney outcomes. And this is, again, one of the older studies which shows that preeclampsia increases the risk of kidney failure years after birth. And this is the cumulative risk of end-stage kidney disease. And what it is showing is that if you have preeclampsia in 2 or more pregnancies, the risk is higher than preeclampsia in one pregnancy as compared to no preeclampsia history. So again, very important for us to counsel our patients if they develop preeclampsia during pregnancy, and then have a regular monitoring of their kidney function postpartum and after delivery as well. The other question we are often asked is there any role of markers in diagnosis of preeclampsia? And a lot of research has been done in the past with several of these markers studied, which we briefly discussed, endoglins, VEGF, placental growth factor, and SFLT1. And this was one of the recent studies which actually showed that if the ratio is greater than equal to 40 in women who present with hypertension, then there is a higher risk of preeclampsia and adverse outcomes within 2 weeks. So again, showing the utility of testing if we really are suspecting preeclampsia. This ratio can help us to predict adverse outcomes and can help us rule out preeclampsia as well. And this did show that if the ratio was more than 40, there was a much higher risk of maternal adverse outcomes, about 6-fold higher. And there was a higher risk of fetal outcomes as well, which was 3-fold higher. Now, this has been FDA approved in US here after the study came out. However, even at my center, we don't have this test available. It's still available at very selective centers. So we are routinely not doing it. But at least we have some data showing that this test can be helpful. Though in other countries like Australia and Canada, they do have access to SFLT levels and placental growth factor, this test of biomarker, and they're using it for their patients. The other thing I wanted to highlight here was that preeclampsia does have long-term outcomes, and that is what's very important for us to counsel our patients on it. So it has shown to have a higher cardiovascular risk in mother, high risk of chronic hypertension, stroke. We did talk about end-stage kidney disease, diabetes mellitus, and even in children, it has shown to have higher adverse outcomes. Now, this is mostly data from single-center retrospective studies, so they do have some limitations, but it did show that even in children, it can lead to higher risk of chronic hypertension, obesity, and reduction in cognitive function. The other question is when to biopsy in pregnancy, and we did discuss briefly this during the presentation. So it is usually a clinical decision based on gestation age, available treatment options, and viability of pregnancy, and mostly to facilitate treatment to improve maternal and fetal outcomes. Especially during pregnancy, we avoid doing a kidney biopsy for prognostication purposes. Biopsy is safe, mostly safe in first and second trimester, less than 25 weeks. Now, if you're needing biopsy in the third trimester, mostly you can deliver the baby and then do the biopsy. That is another option. And the other option is to do biopsy postpartum. I think the case we briefly discussed had a biopsy postpartum, mostly because I think it was for prognostication and patient was not improving. And this is just briefly showing that timely diagnosis is very important, and we need to remember there is lack of diagnostic criteria. We should do routine screening of kidney function, do basic urine analysis, kidney ultrasound, and serologies, depending on the type of cause of AKI which we are suspecting. Kidney biopsy facilitate treatment to improve maternal and fetal outcomes, and do biopsy in first and second trimester, less than 25 weeks. Identify the cause, intravenous fluids, and treatment of other complications of AKI is similar to non-pregnant patient. For example, if we need dialysis. And these are showing the specific treatment options by the cause of AKI. And as the for hyperemesis gravidarum or prenatal causes, hydration is the treatment. For septic abortion and UTI, we would do antibiotics. Preeclampsia help or acute fatty liver of pregnancy is delivery. We did talk about TTP. It's plasma exchange, and rituximab can be used in some cases. Atypical HUS is usually eculizumab. If you have obstructive uropathy, analgesic stent, and nephrostomy, placental abruptio is control bleeding and delivery, and glomerulonephritis is steroids and immunosuppression. The other thing I briefly wanted to highlight was treatment of hypertension in pregnancy, and the case we discussed also had hypertension. So in the past, the therapy was only initiated when systolic blood pressure was more than 160. The guidelines only changed a couple of years back with this CHAP trial, which was published, which was a randomized control trial, where there was evidence to show that initiating therapy with systolic more than 140 and diastolic blood pressure more than 90 does improve fetal outcomes. So the goal blood pressure for systolic blood pressure is 120 to 140, and the goal blood pressure for diastolic blood pressure is 80 to 90. And these are, this is the figure showing some preferred medications. So labetalol, nifedipine, and methyldopa are the preferred medications. I usually use nifedipine. I think it works great, especially the extended release. And also labetalol works good, but it has to be given thrice daily. So that is one of the challenges. Another thing to remember is to always give aspirin in any patients with chronic kidney disease, kidney transplant, as this is the only intervention which has shown to reduce preeclampsia. So it should be started at the end of first trimester, at the end of 12 weeks. We should avoid ACE and ARBs because they are teratogenic. Also, atenolol can cause intrauterine growth restriction, so should not be used in pregnant patients for treating hypertension. And spironolactone, again, should be avoided because of fetal anti-androgenic effects. As we discussed, delivery is the most definitive treatment, and preeclampsia usually resolves after delivery. And the other thing is breastfeeding is safe. Is safe. However, we just have to make sure they are on safe medications. Even it is safe for them to be on captopril or enalapril when they are breastfeeding. Methyldopa can cause postpartum depression. So if any women is getting methyldopa, we should stop it because it does potentiate postpartum depression. And if they're breastfeeding, we should stop methyldopa. So in brief, this is our role to educate about the risk factors and outcomes, timely diagnosis, support them. And this, again, I wanted to highlight is like have a shared decision-making with our patients, avoid a paternalistic attitude, just counsel them about adverse outcomes, especially when they develop, even when they develop pregnancy-related AKI, because we did talk about that AKI can have adverse fetal and adverse maternal outcomes. So the patient which we discussed was postpartum, but if you see AKI during pregnancy, that can be really challenging with regards to fetal outcomes as well. Treat the underlying cause, and again, multidisciplinary care becomes very important, especially if women develop AKI during pregnancy as well. As we were talking, most of the time they may need neonatal and intensive care admissions. So it's very important for us to make sure they do have those facilities available. So to summarize, pregnancy-related AKI ranges around 0.08% and has increased in the recent decade. The common causes include hyperemesis gravidarum, in addition to preeclampsia and thrombotic microangiopathies. Diabetes, older age, and preeclampsia increases the risk of pregnancy-related AKI. AKI in pregnancy is associated with a higher risk of maternal mortality and cardiovascular events. And it increases the risk of adverse fetal outcomes, include preterm births and perinatal mortality. There's a lack of diagnostic criteria for pregnancy-related AKI, and treatment of pregnancy-related AKI includes timely diagnosis of the underlying cause, disease-specific treatment, hydration, antibiotics, immunosuppression, and prompt fetal delivery if necessary. So thank you for having me, and thank you to my research team, mentors, collaborators, family. And this is one of the guest issues I had done for Advances in Chronic Kidney Disease on women's health and kidney disease, and it has some excellent articles, including an article on pregnancy-related AKI. So thank you so much for having me.
Thank you, Silvi, for wonderful overview of the issues which can develop during pregnancy. I think we ask the questions from the audience and the faculty if there is any clarification sought. Just one or two questions. Any role of iptacopan if the eculizumab is not there?
So I haven't used iptacopan. In my understanding, I'm really not sure if we have evidence to use it. So I haven't used iptacopan. Yeah.
Second, how often there you get in India? A lot of time we get focal or diffuse cortical necrosis as part of puerperal sepsis or epilepsy placenta or PPH, like this patient had PPH, but it was not a massive bleed this time. How often you have in US or other countries?
Very rare. So it's extremely rare we get acute cortical necrosis. Actually, I had one patient long time back, and we actually wrote a case report on it for Clinical Kidney Journal just because it's so rare. So so and they accepted it. So extremely rare. We hardly see it.
Faculty, any questions and clarifications?
Yeah, I think I would say that to answer the question as to why is it that we see acute cortical necrosis so often and the rest of the world doesn't see it as often, it's a problem predominantly of the developing world where pregnancies are not monitored the same way as this is in the Western world, and therefore many pregnancies the diagnosis is made very late, and by the time we make the diagnosis, many of these patients have had significant ischemia of the kidney and acute cortical necrosis. So in the rest of the world, in the developed world, I think these things are monitored. Diagnosis is made very early and treatments are available. Unfortunately, even if we make the diagnosis early, treatments may not be available to vast majority of our patients. But my only one point is that the residents must know about the current treatment. And there are significant number of patients now, when you talk to them about eculizumab and the cost involved in it, at least the initial treatment will be, if you don't know it, you will never be giving this option to the patient. But if you know about it, then you give the option to the patient, let the patient decide about it, whether they can afford it or not. And many times when you look for it, you make it available. And that's the reason why we have been able to use it in some of our patients, and we've been able to do quite well in those patients wherever we have used it.
So adding to what Kher sir said, so cortical necrosis, we had published our data from our center. So around 300 cases, 100 underwent a renal biopsy and 50% had cortical necrosis, either patchy or diffuse. So as you said, and many of these patients were unbooked cases, they directly landed on the day of delivery in the gynec hospital as well. So booked cases, now it's coming down happily and we are not seeing so much of cortical necrosis.
But still, Manisha, we have many cases of
yes.
In our practice, many times we see because of puerperal sepsis they are developing, because of whatever bleeds they are developing. That's all right. That
Can I ask? Can I ask Silvi one question? Dr. Silvi, we have seen two patients with cytokine stimulation related to intravenous these IVFs being conducted in people when they give large amounts of hormones. So two cases of acute cortical necrosis occurred in young females related to the ovulation stimulation and drugs being given, and they developed some kind of a cytokine syndrome. And then we investigated these patients and found out that there in the literature as well, there was some case reports about this kind of a syndrome with acute cortical necrosis. Have you ever seen this kind of thing since you are related?
So I did see in one of the patients ovarian hyperstimulation syndrome. We did see in one of the patients. And we did, but again, it's rare. But but it's not. It did not have cortical necrosis. It had AKI.
Okay. So we had two ladies. Although at Medanta we didn't have a gynae department as such, an obstetric department, but these were patients who had this developed this syndrome outside, and then they came for management in our cases. When we biopsied them, and we found that they had two cases, and this was for the first time I had seen this kind of a thing. But when we looked at the literature, well, there were some case reports of acute cortical necrosis with hyperovulation stimulation.
There are a couple of questions from audience. One is, why is acute cortical necrosis common in trachea as compared to other causes of AKI? I don't know. I don't know why, but yes, it is. It is definitely more common in Indians.
I think Girish will answer that question.
Yeah. And Dr. Varma, probably those who are graduates from PGI would remember that and pregnancy, as it is, all of us know, is a stage where you have a very active and hyperactive endothelial surface. And the response to any stress is much more than what we expect in a non-pregnant state. In an experiment model, we talk about the Schwarzman's phenomena. When somebody is exposed to a endotoxin, they have various thrombosis in the various organs, including spleen and other things. And when they're exposed to the second dose, they have an accelerated Schwarzman phenomena. Pregnancy is something like an accelerated Schwarzman phenomena. In the endothelium is already primed for it, and the exposure of this will precipitate and cause a diffuse intravascular coagulation, cortical necrosis. That's why more common in pregnant as compared to a non-pregnant state.
Another question which has come for Silvi. How much sensitive, she did mention that FSLT1 and PIGF, more than 40 is pretty sensitive to pick up preeclampsia, but how specific it is to pick up MAHA postmortem?
No.
Oh, it's not. No, it's not.
Not for MHA.
Yeah, not for MHA.
Not for. Another question somebody is putting, how many weeks we should wait for doing kidney biopsy to rule out cortical necrosis? Nothing. There's nothing. We have done a week after or even earlier. Any comments?
No, I agree.
Whenever you can do it, if you feel the patient is anuric and you have all the indications for a biopsy, then I think, and if the clinical condition is not contraindicated, then I would do a biopsy as early as
Dr. Kher, for the sake of our residents, I thought I will just reiterate that normally when the patient is anuric and you have a clinical setting where you expect that the patient had a prolonged hypertension or DIC or settings where they are likely to develop cortical necrosis, in such patients, probably as Dr. Varma has pointed out, biopsy can be done at any time as per your assessment. But otherwise, in an uncomplicated AKI in the obstetric setting, normally we expect the recovery to occur within an average 2 weeks. And those patients who are anuric and the clinical picture doesn't suggest that it is an ATN, then in that situation, certainly we would like to postpone the biopsy till at least around 2 weeks before we contemplate a biopsy in this setting.
Ordinarily, if the ATN, if the diagnosis was ATN and the patient doesn't recover in usually 4 weeks' time, then one would do a biopsy.
A question for, I think, Manisha. Any definite test to differentiate between TMA and HELP?
So, see, the thing is, most important clinical clue is that generally preeclampsia and HELP, they start recovering by 3rd week, and TMA, HUS typically does not recover within that time. And then the important thing is, if you have, and it's mentioned in literature also and recent articles from Silvi and from Dr. Anuja Java as well, that in case by 72 hours, if the LDH is more than 600 and the platelet count is low and the creatinine is high, it almost rules out a preeclampsia HELP, and it's most likely HUS. Third important point is, in HELP, you have abnormal coagulation parameters you might have, whereas in case of TMA, the coagulation profile is completely normal. The 4th point is, in HELP, liver enzymes are always elevated. It's one of the defining features of HELP, whereas in TMA, the liver enzymes are generally normal. So now if you ask for 100% test, again, I think you are not going to have any.
It's a clinical. All these are clinical diagnoses.
Last one for Suguna. Is she around?
Yes, sir. I'm here.
Okay. So how do you calculate GFR in pregnant women? By EPI, MDRD? How?
No, sir. Those none of those equations are actually validated in pregnancy because of the underlying physiological changes. So, gold standard in pregnancy would be timed actually inulin 24-hour inulin clearance would be the gold standard in pregnancy.
Otherwise,
Suguna,
That's
just
very
just
nice. It's a
another question,
time.
Suguna.
Yeah, it's a
Now that
very nicely said. It's a time collection. The creatinine clearance is the gold standard, not the EPI or MDRD.
Yes, sir.
Yeah. Uh-huh.
I think that's it. Probably, if there are any other doctor, I think we should ask Dr. Girish.
Dr. Girish,
Give
your
us.
final comments.
He's already given a lot of answers
Yeah.
and asked questions.
No, but basically, I must congratulate all the participants, especially Dr. Suguna, who presented very well. Interaction, Dr. Manisha did coordinated and did very well. I'm sure the postgraduates today and other participants would have enjoyed the a very elaborate discussion we had on this topic. So I think this has been a very session which has been of very beneficial to all our residents and other participants. I thank them all, and obviously, I thank the organizers for giving me this opportunity today to participate in such an important discussion, which is
just
very
one
common
one
in our clinical
one
practice.
question, Girish, to Manisha or to anybody. Do we still see cases of septic abortions, Manisha? Especially you are working in government hospital, and do
so
you
no,
see
ma'am.
septic abortions?
No, ma'am, we have not seen, I mean, in the last 10 years. And actually, most of the literature on Praki before 20 years or 15 years was the commonest cause in early pregnancy was a septic abortion. And there are published reports from I think, BHU, lot of reports by Dr.
Yeah,
Prakash and
even
all.
PGI
And
Chandigarh did
other,
early.
yes, and other published
70s,
reports
70s
from,
and 80s was
yes,
Was
all.
all
yes,
septic
and
abortion.
yeah.
We
So,
have also analyzed our data over three time periods. In 70s, like Dr. Kher says, septic abortions were more common. But from 80s onwards, preeclampsia started
Yeah,
to be more common. Now it is the commonest cause of
yeah,
Praki.
yes.
Is there a difference? Is there any regional difference in the etiology of Praki?
so ma'am,
I don't think so.
so I mean, like we have analyzed the different parts of the world and different parts of India, and overall we found three causes, ma'am, mainly obstetric hemorrhage, puerperal sepsis, and preeclampsia. So in some of the centers, the obstetric hemorrhage is the commonest cause. In our center, it's preeclampsia. But overall, these are the three topmost causes. And septic abortion is now nowhere in the top 3 list. In the Western developed world, it's mostly preeclampsia, mostly. And Praki, in fact, is going up a little bit in the Western world because of a later age at conception, assisted reproduction, all those things. So otherwise, overall, Praki has come down. So what my take has been and learning has been in the past few years is like we should not miss thrombotic microangiopathies. Earlier, as Dr. Kher also pointed out, many of the cortical necrosis and all that, we did not even have an etiology. So most common etiology remains preeclampsia, HELP syndrome, especially. Preeclampsia HELP is a deadly combination, most common cause of AKI. But within 3 days, if it's not improving and you have a picture of thrombocytopenia, you should think of complement-mediated HUS because you can change the prognosis if you diagnose it early. Schistocytes are very important. Another important point is schistocytes may not be present. It's not mandatory. If they are present, it's very important. But absence of schistocytes does not rule out if you have other evidence of hemolysis. So that's very, very important. Sometimes patients are given blood transfusions and you may not be able to find out the schistocytes. So any hemolysis, low hemoglobin, reticulocyte high, Coombs negative, all other autoimmune negative, this should be high in your mind. Always send off a complement test and genetic test. At least keep the sample at -20, even if you can't send it immediately. So if the patient is not improving within 3 days to a week, that's the time you send off the samples. If you are not able to send them upfront, you can store the samples at -20 for a week, and -70, you can store them for months. So that's what we are doing. So that's another important point. we were doing a complement and thinking it's not HUS because complement is normal. But remember, complement can be normal even in atypical HUS, complement mediated HUS in 20 to 30% of the cases. The other important thing is that don't only send NGS and clinical exome. Always think of MLPA because some of the mutations, especially the CNVs and all, can be picked up on the MLPA. So these are some important points which could change the prognosis for the patient. And as Dr. Kher said, we should offer them the option of eculizumab. We should tell them, and shared decision making is the way to go ahead, I think. So it's
very, very well said.
Can I make one point, Dr. Verma?
Yeah.
Just a minute.
I think you answered my question also. I'm just asking, has anybody followed these patients of cortical necrosis, diffuse or patchy? Why I'm saying that, two of my patients who had developed diffuse cortical necrosis, diagnosed on biopsy, obviously, fortunately, they have been doing exceedingly well.
No.
That is what I'm saying.
Dr. Verma, yeah. Before we going on to Dr. Kasi, Dr. Verma, your comment, I would like to just answer that. When we do a biopsy for a suspected cortical necrosis, it is just a coincidence. We may strike a patch which is necrosed. And all of us know that it is a patchy cortical necrosis. There are certain healthy areas, and there could be some useful recovery in rest of the other renal parenchyma. So kidney biopsy is not always a very certain test of documenting a diffuse cortical necrosis, but certainly, as you rightly pointed out, the differential diagnosis of this is, but as you might have possible that you have missed a patchy cortical necrosis, and by coincidence you must have struck a necrosed patch during your biopsy. So that
CT scan, maybe
CT scan, later on,
3 months probably later might be able to pick up a diffuse cortical necrosis on a CT scan.
Even in those cases who have histological cortical necrosis, we know that physiologically some of the subcortical area of the kidney would have some useful recovery so that the patient remains without dialysis, although with a reduced GFR and compromised kidney function, patient may remain off dialysis or it's possible that over the next few years, months or years, the remaining functions may deteriorate again and she may land up on dialysis. Now, before Dr. Kasi wanted to make some comment. Dr. Kasi?
Yeah, I can remember one patient of a snake bite with patchy cortical necrosis, biopsy proved, who was on dialysis for about 8 to 10 weeks, went off dialysis with a creatinine of 5 milligram. After 10 years, the creatinine had improved to 3 milligrams. And then gradually she worsened and then ended up in end-stage renal failure in about 20 years' time.
Yeah.
We have also done studies earlier, but they are unpublished, on patients who had preeclampsia and then continued to have hypertension proteinuria after 6 weeks. And we did a biopsy. And most of the biopsy showed focal segmental. So presence of pre-existing kidney disease makes them more prone to development of preeclampsia.
Yeah.
This is an unpublished data. We have done prospectively biopsies on patients who had persistent hypertension following what is called a preeclampsia. So I just wanted to add this because in this context it may be significant.
Yeah, it has also been documented that if you have preeclampsia in the second and third pregnancies, or you have it more than one pregnancy, if you have it in the first pregnancy only and then you don't have it, then it's purely preeclampsia probably. And their long-term outcomes, as Silvi showed in one of the slides, that their outcome may not be as bad, long-term outcomes of cardiovascular disease, but it is those who have preeclampsia where there may be an underlying cause. Those who have preeclampsia in the second and third or multiple pregnancies may have an underlying cause of kidney disease or underlying essential hypertension, which may be predisposing to preeclampsia. And then their outcomes are obviously related to the underlying causes of preeclampsia, which is usually an underlying kidney disease like FSGS or maybe essential hypertension as well. And these people are obviously not going to do as well and will have high cardiovascular disease and all that. And this was what Silvi showed also, the chronic kidney disease in them was much higher in comparison to those who had only preeclampsia in the first pregnancy.
I think
I think Dr. Kher has very important point about it. Just for the sake of our residents, I would like to, before making a diagnosis of preeclampsia after the second pregnancy, think twice before making a diagnosis of preeclampsia, because you might be missing an underlying. Dr. Kasi was pointing out, and Dr. Kher said, you might be missing an underlying renal parenchymal disease with a superimposed hypertensive disorders of pregnancy. Because as per our original concept and decisions, the preeclampsia was disease peculiar to the primates. Although the spectrum has changed, but our classical teaching was that preeclampsia is a disease of a primates.
Suguna is there.
Yes.
Dr. Verma, there is still 1 minute left.
Right.
Maybe we can ask her one question.
G.
Suguna, tell us preeclampsia in the first trimester. What are the causes of preeclampsia in the first trimester?
Wonderful, Dr. Kher. Thank you.
Okay, if it happens in first trimester, sir, a few things that we have to rule out first are molar pregnancy, and then we have to rule out Apla syndrome as well. And there might be multi-fetal gestations as well. And there could be underlying lupus nephritis, underlying HUS and
The
TB
underlying
as well.
renal disease or underlying hypertension.
Yes,
So when
yes.
you have an underlying hypertension and underlying renal disease also, then you may have preeclampsia like
Earlier,
disease
yes.
earlier in the first. And obviously you talked about. So you know all the answers
done
quite
very
well.
well,
So
yeah.
you need to be congratulations. And I think General Verma, maybe we can conclude now. And I must say that I must congratulate Suguna for being so well informed and well read. And congratulations to Dr. Manisha Sahay, whose student she is, and obviously a good student speaks also of a good teacher as well. And I think congratulations, Manisha and Suguna. And I must say, Silvi, Shah, thank you very much for being and for giving us a wonderful talk, and almost covered all the areas which were related to Praki, and I think, and gave us an overview of the complications that can happen long term in many of these patients. Thank you, Silvi, for joining us, and also on a weekday early morning and from US. And I must thank also Dr. Girish Narayen for keeping us active. Actually, he was truly active participant today, not an expert as we usually see. So thank you for being there. And then I on behalf of Steadfast as well as the Kern Foundation would like to thank all the participants and everyone else who joined us. And these classes are started to become very popular, and a lot of people, not only students but a lot of senior teachers also attend these classes. So I think and their participation and asking questions again makes it very, very important and useful to the students as well as to everyone else. Every day there is a new learning, and I'm sure we keep abreast of the new things that are happening. And thank you very much, everybody, and good night. Bye-bye, and have a good day, Dr. Silvi, and all the best. Thank you very much. I hope we have you again sometime.
Thank you so much. Yeah.
Thank you.
Congratulations again, Suguna, Dr. Sahay.
Thank you so much, faculty. This was truly an amazing session to a masterclass. Thank you so much and good night.
Good night. Thank you.
Good night.
Okay, bye-bye.